Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's very important video session, we are going to again discuss the most important questions concept for our upcoming Norcet exam. So, I want everybody's active participation in the comment box, and wherever I am asking the question, so please do try to involve and please do try to mention the correct answer in the comment box. Okay. So, very good evening to one and all. Welcome you all to the Master Nursing classes. Good evening, beta. Good evening. Good evening. So, well done, beta. So yes, we will start the today's session with this powerful motivational line. So let me wait for a 3 to 4 second more. Okay, so few of your friends need to join, and who are live to the session, so fatapat hit the like button. And if anyone of you are watching the Master Nursing classes first time, so please do subscribe to the channel, because this channel is the channel which is not wasting your single minute of the time and which is completely focusing on your success. Yes, if someone is working for you, one like we deserves. Yes, so fatafat hit the like button, and if anyone of you are new to the channel, so please do subscribe to the channel. A very good evening to one and all. So can we start the session? Is that sound, video, everything is clear? So fatafat do mention in the comment box. Yes, please do thumbs up. Well done. So we'll start the today's session. Yes. So here's the powerful motivational line in front of you people. So students, always do remember, big things takes little more time, little more discipline, little more motivational level, and little more your own potentialities. This is not easy work. So that's why only you people are here to perform this one. Yes, you all are made for to easily do the difficult works, right? So this is somewhat difficult, but don't feel it difficult. Try to enjoy this particular difficulty, so it will definitely makes you a very strong person in your future, right? So always think this process is not easy. That's why the God given this particular work to you people to perform and win the and to show the world you are having the potential to do something in your life. Yes, so your own people will wait for your failures, your own people will hate you. Okay, your own people will say some negative words, not others. Okay, so try to be away from those people, right? And try to improve yourself and believe in yourself. Why? Because this is little bit lengthy process. This is a little bit process which requires some more discipline from you all. Yes, so that is the reason. Always believe on yourself and push hard how much it is possible, because this is a time to work more, right? So remember the word, big thing takes time, and if you work on time, next coming all time is yours, right? So with this powerful motivational line, so we will start today's session. Here is the first question in front of you all. So please do read the question carefully, completely, and try to mention the correct answer in the comment box. Yes, which of the following is the most common cause of the ARDS? ARDS means the acute respiratory distress syndrome. We also call this particular condition as the non-cardiogenic pulmonary edema. So, which of the following is the most common cause of the ARDS or the non-cardiogenic pulmonary edema? Yes, I'm waiting for your response in the comment box. Option is the asthma, option B is the pulmonary embolism, option C is the sepsis, and option D is the lung cancer. So what is the correct answer? Well done, beta. Few of you have given the correct answer for this particular question. So there is a sepsis goes to the correct answer. I told one word initially. So there is the another name of the ARDS is the non-cardiogenic pulmonary edema. Sir, why you told this particular word? Beta, you have to understand one basic concept here. Usually pulmonary edema happens due to the heart failure. Sir, how, sir? Let's listen the concept here. So this is our beautiful heart, and this heart is divided into right and left by the septums. Okay, so right atrium and left atrium is divided by the intra-atrial septum. The right ventricle and left ventricle is divided by the intraventricular septum. Okay, so this is the left part of the heart. Okay, so which receives the blood from the lungs. Okay, so this is the lung. Okay, so right part of the heart which sends the blood to the lungs for the purification by the pulmonary vein. Okay, so this pulmonary vein which is rich in the carbon dioxide rich blood, and it will send the blood to the lungs for the purification. So now lungs will give the oxygen, and the oxygenated blood will comes return to the our left atrium. Okay, so through the pulmonary veins. Okay, so pulmonary veins are the veins which are responsible for the receiving the blood from the lungs. Okay, so that is the oxygenated blood will be received by the left atrium. Okay, and which are carried by the pulmonary veins. So hope it is clear to every one of you. If in case this left ventricle is getting failure, okay, left ventricular failure is there, or the left ventricular dysfunction is there, means whichever the blood which is coming here, okay, so that blood it will get congested there. Sir, how, sir? The blood in the left ventricle, it will not move further. So because of the left ventricular failure, the blood will start to congest in the left ventricle, and the left ventricle is congested means left atrium will get congested. So the left atrium is get congested means the pulmonary veins will get congested, and the pulmonary veins will get congested means here the pressure inside the lungs will increase. Okay, so that the pulmonary capillary wedge pressure will increases in the case of the cardiogenic pulmonary edema. Okay, so here the fluid will leak. Here the fluid inside the lung will leak. Okay, so fluid inside the lung is leaking means we call that one as in the pulmonary edema. Okay, so the pulmonary edema is the accumulation of the fluid in the lung tissue, not in the pleural space. Better if this is the lungs and this is the covering of the lungs. Okay, so inside this covering of the lung, if the fluid is accumulating means I call this one as in the pleural effusion. Okay, so inside this lung only the fluid is accumulating means I call that one as in the pulmonary edema. Okay, so due to the left ventricular failure or the left atrial failure, so there will be a congestion of the pulmonary veins. Pulmonary vein congestion means the fluid will start leak in the lungs. Okay, this is what you call as the pulmonary edema, that is due to the heart failure. So I call this one as in the cardiogenic pulmonary edema. Okay, so I call this one as in the cardiogenic pulmonary edema. But in case of the ARDS, this all process is not happening. That is what we call the ARDS as in the non-cardiogenic pulmonary edema. Sir, this all process is not happening means what actual thing is happening, sir? Yes, let me explain the thing for you all. Okay, understand what happens in the non-cardiogenic pulmonary edema, or what happens in the ARDS situation. So this is the our alveoli. Okay, and this is the blood which is supplying the blood vessel which is supplying to the blood to the alveolar level. Okay, so this one what we call the respiratory endothelium, right? So here the air will get enter, and here the air will get exchange between the blood vessel and the alveoli, right? This particular alveoli and the respiratory endothelium, so this one it will get damaged. Why, sir? It will get damaged due to the inflammation. That may be due to the pneumonia. That may be due to the sepsis, or that may be due to the trolley. Sir, what is the trolley? Whenever we will give the excessive amount of the transfusion. So, for example, in the massive blood transfusion, circulatory overload will happen. So that may lead to the transfusion-related acute lung injury. So that one what we call as in the trolley. Okay. So in this trolley, that due to the fluid overload here, so this particular respiratory endothelium and alveoli will get damaged. So here the oxygen exchange will impair. So that is what we call acute, means it happens suddenly. It is not progressive one. Suddenly, immediately it will happen. So, okay, that is the acute, and here the respiratory distress is happening due to the damage to the respiratory endothelium and the alveoli. So, which will create the group of the sign symptom. We call that one as the syndrome. Okay. So, the overall we call this one as the acute respiratory distress syndrome, which is not happening due to the cardiac failure. Okay, so if it is happening due to the cardiac failure, I call that one as the cardiogenic pulmonary edema. It is happening due to the pneumonia, it is happening due to the sepsis, it is happening due to the massive blood transfusion. So that is what we call as a non-cardiogenic pulmonary edema. Beta. So in the cardiogenic pulmonary edema, I told here the a pressure inside the endothelium will increases. Okay, so that is the pressure. So pulmonary capillary wedge pressure will increases, I told, in the cardiogenic. But in the ARDS or in the non-cardiogenic, the pulmonary capillary wedge pressure, it will be normal only. Okay, it will not be increased, it will be normal. So that is the special feature which will differentiate the both cardiogenic and non-cardiogenic pulmonary edema. Okay, hope the concept is clear. So let me quickly revise the golden points on the our ARDS. Okay, so ARDS we also call as a non-cardiogenic pulmonary edema. Okay, so this is the very important one. The most common cause is the sepsis. Better, you will have the two types of the causes for the non-cardiogenic pulmonary edema. Okay, so one is the direct cause, another one is the indirect cause. Okay, so in the direct cause we have the mnemonic call, that one as the MyDPT. So what is DPT? DPT is the vaccine, right? So you can remember it's MyDPT. So it's the MyDPT. So M stands there for the Mendel's syndrome. What is Mendel's syndrome, sir? Sir, what is the Mendel's syndrome? Yes. M stands there as the Mendel syndrome. So what is the Mendel syndrome? Better, in a situation of the intraoperative period, if the patient, due to the anesthesia effect, entire GI content is coming back and the patient is aspirating the entire GI content, and there is then the aspirational pneumonitis is happening to the patient, we call that one as the Mendel's syndrome. So in order to prevent the Mendel's syndrome, for every preoperative patient who is undergoing the general anesthesia in the intraoperative period, for all the preoperative patients, the doctor will prescribe the proton pump inhibitors called as the PANTUP. Okay, so injection PANTUP will be given to all the preoperative patients in order to prevent the Mendel syndrome. Okay, so do remember, if the Mendel syndrome happens, means all the GI content will come and it will get enters into the trachea, and the particular lungs becomes inflamed due to the aspirational pneumonitis. Okay, so very important, consider. So in the Mendel syndrome, it will causes the directly it will causes the ARDS or the what we can say a direct cause of the like non-cardiogenic pulmonary edema. Okay, so another T stands here is the if any toxemia. Okay, so if any toxemia in the blood, there is an excessive toxic is there, so which will cause the again direct cause of the our ARDS. Or if it is causing due to the pneumonia, infection and inflammation of the lung parenchyma. Okay, or it may be causing due to the drowning effect. What is drowning? Drowning under near dost. Okay, so patient is going deep inside the water and aspirating the water, so that's what we call the drowning. Okay, so these are the direct causes of the ARDS. How to remember the indirect causes? You can remember indirect MSC. So that is a patient is undergoing for the massive blood transfusion, or the patient is undergoing for the sepsis, and patient is having the chest trauma. So in this all situation, we can call this one as the indirect cause of the ARDS. Okay, so please do remember this particular sepsis. This particular sepsis is the overall most common cause for the ARDS, or the most common indirect cause of the ARDS. The two questions may arise from here. What is the most common indirect cause of the ARDS? So that is our sepsis, the indirect most common cause of the ARDS. What is the overall most common cause of the ARDS? Again, our answer goes to the sepsis. So please do remember the very important one. If the examiner is asking most common direct cause of the ARDS, so that is the pneumonia. Okay, so most common direct cause of the ARDS is the pneumonia. Most common indirect cause of the ARDS is the sepsis. Most common overall, okay, most common overall cause of the pneumonia is also most common overall cause of the ARDS also sepsis. So very important, please do remember the golden points here. Okay, sir, here is the most common cause, That's overall indirect. Sepsis, most common direct cause pneumonia. But in exam, which one will be asked, sir? Indirect cause only will be asked, or the overall most common cause will be asked. So that is the sepsis will be your answer. Okay. So in order to diagnose the ARDS, we have one criteria. So the name of the criteria is that is the Barlin criteria. So according to Barlin criteria, so ARDS situation is not happening for the chronic, it is not happening for the long time, it will be sudden and it will be acute. Okay, so according to Barlin criteria, the ARDS will happen acute. Okay, so that is within 1 week of the trigger. So trigger, it may be here in the sepsis, it may be a trauma, it may be a pneumonia, it may be a massive blood transfusion, it may be a Mendel syndrome, whatever it may be. Within 1 week of the any kind of the damage, so the ARDS will happens. Okay, so along with that, the second one, imaging. Whenever we will take the patient chest X-ray in the ARDS, it will looks like a bilateral whiteout line. So not one side, it is both the side the patient lungs will look white out. Okay, so we can call this one as the bilateral infiltration or the bilateral whiteout lung. Okay, in the X-ray of the ARDS, how we will see X-ray of the ARDS will be, this is very important point, beta. So it was asked in the exam. X-ray of the ARDS, yes, there is the bilateral complete infiltration will be there, and bilateral whiteout lung we will see, and sometimes we call this one as the wet lung syndrome. Okay, why? Because the fluid is accumulating inside the lung tissue. Okay, so very important. Consider the point. So the next one is the origin of the edema. It is not fully explained by the cardiac failure, and it is not fully explained by the fluid overload. It is happening due to the septic causes and the alveolar damage and the respiratory endothelial damage. So that is due to the inflammatory causes at the alveolar level. Okay, so there is no any left atrium hypertension will be there. If the left ventricular hypertension, left atrial hypertension, and increased pulmonary capillary wedge pressure, so that is happening due to the cardiogenic pulmonary edema. So that is due to the left heart failure. So it is happening due to the septic and other causes. So there is no any left atrium hypertension will be there. Please do remember the word. Okay. So oxygenation, there is the PaO2 is to FI, like partial pressure of the oxygen is to a fraction of the inspired oxygen. So ratio will be less than 300 mm per G. So based on this one, we have the types of the ARDS also. If the FaO2, that is the partial pressure of oxygen, is to PaO2, that is the partial pressure of the oxygen, is to fractional inspiration of the oxygen. So the ratio, if it is between the 200 to 300, so that is the mild ARDS. Okay, so if it is 100 to 200, moderate ARDS. If that one is less than 100 mm per G, so that is the severe ARDS. Okay, sir, what to give in the treatment of the ARDS? So please do remember the special words here. Always we will give the low volume ventilation. Why? Because in the alveolar level already pressure is there, already fluid have been accumulated. So if we are giving the high volume ventilation, again remaining alveoli also will get damaged. So in order to avoid that one, we will give the low volume ventilation. Usually better the 12 ml per kg will be calculated and will be given. But in the ARDS only we will give the 6 ml per kg of the ventilatory volume. Okay, so that is the very important. Please do consider this one. Okay, so we will give the low volume ventilation. And which position we will give in the patient with ARDS? So prone position ventilation will be recommended one. Okay, so very important. Even we given the ventilator supports and prone position, but the patient still is desaturation. So that time, even ventilator fail means we have to do the oxygenation outside the body. So by the use of the ECMO machine or the ECMO machine, what we call this one is in the ECMO machine or the ECMO machine or the artificial heart lung machine we will say. So that is, it is doing the outside the body, extracorporeal. Corporeal means body. Yes, tinea corporis. What is the tinea corporis? Corporis means entire body. Okay, tinea means yes, the fungal infection of the entire body we call the tinea corporis. Here the corporeal or the corporis stands for the body. Okay, so extracorporeal means outside the body. We are doing the oxygenation. Okay, so that is what we call the extracorporeal membrane oxygenation. So that one, the oxygenation of the blood will be performed outside the body, because whatever the normal machine we have here, that the both lungs, which is responsible for the oxygenation of the blood. But the both lungs are completely filled with the fluid, that is due to the septic causes or any other causes. So this oxygenation is not happening by our normal lungs. So this oxygenation procedure we will perform by using the ECMO machine. So ECMO full form is extracorporeal membrane oxygenation. Here the ECMO or the extracorporeal membrane oxygenation means the oxygenation of the blood will be performed by the external artificial machine. We call that one as the extracorporeal membrane oxygenation. Hope the concept is very much clear on the ARDS. Better, if question comes on ARDS, definitely it will come from these golden points only. So if it is not coming means yes, it will not go or it will not extend out of this particular box what I have explained to you people. Okay, so this is more than enough for your current exam. Okay, so yes, if time permits, every topic what I am teaching in the rapid revision I will take in detail only, so that is free of cost, don't worry, right? So here is the next very important question in front of you. So please do read the question carefully, completely, and try to give the best answer for this particular question. Yes, which of the following pressure is typically elevated in the cardiogenic pulmonary edema? Already discussed the question. So please do mention the correct answer. Which of the following pressure is typically elevated in the cardiogenic pulmonary edema? Already the pathophysiology I have discussed with you people. Yes, option A, central venous pressure. Option B, intracranial pressure. Option C, pulmonary capillary wedge pressure. Option D, intra-abdominal pressure. Better, in the cardiogenic pulmonary edema, the pulmonary capillary wedge pressure will increase. Okay, sir, how? Already I have explained to you people. Okay, so again I will come to the same diagram what I have drawn for you here. Okay, so look at this particular diagram. So this was our heart. Okay, so this is the left ventricle. The left ventricle is getting failed here, and the pressure in the left atrium increased, and the pressure in the pulmonary veins increased, and the pressure in the pulmonary veins increased means the pressure in the alveoli of the at the level of the gas exchange. Okay, that is what you call the capillaries of the pulmonary vessels. Okay, so that is the pulmonary vascular wedge pressure will be increased here. Okay, so or you can say pulmonary capillary wedge pressure will be increased here. Okay, so that is the very important. It happens in the cardiogenic pulmonary edema, but pulmonary pulmonary capillary wedge pressure will be normal in case of the non-cardiogenic pulmonary edema, or in the ARDS the PCWP is the normal. Okay, the PCWP will increase only in the left heart failure. Okay, so please do remember. And here is the heart failure is happened, so this cardiac size will be big. Okay, so this is the cardiomegaly will happens. Okay, so cardiomegaly will happens in the cardiogenic pulmonary edema, but in the non-cardiogenic pulmonary edema the cardiac will be, the heart will be in the normal size only. Okay, so that is the reason whenever we will see the X-ray of the cardiogenic and the non-cardiogenic, in the cardiogenic pulmonary edema, so there is the cardiophrenic ratio, means the ratio between our what we can say heart and the diaphragm, like we will take a ratio. So already we have discussed in the X-ray the cardiophrenic ratio will be increased in the cardiogenic pulmonary edema. Okay, in the non-cardiogenic pulmonary edema heart is not involved, so heart will be normal size. Okay, so there is no any cardiomegaly means the cardiophrenic ratio or the cardiophrenic ratio will be, it is normal only in case of the ARDS. In case of the cardiogenic pulmonary edema it is increased. Okay, so let me quickly revise and give the best all the difference between the cardiogenic and non-cardiogenic pulmonary edema, so it will be very much helpful for you all. Okay, so here will be a classical differentiation between the cardiogenic and the non-cardiogenic pulmonary edema, so please do focus here. Okay, so what is the primary cause of the cardiogenic? It is happening due to the left-sided heart failure. Okay, that one we have discussed. Okay, yes, so what is the primary cause of the non-cardiogenic pulmonary edema? So this may be due to the ARDS, or it may be due to the another causes like a sepsis, pneumonia, massive blood transfusion associated lung injury. Okay, especially the injury is happening at the capillary membrane of the alveoli. Okay, so that is the already we have explained. Okay, respiratory endothelium and the alveoli will get damaged due to the septic or the other conditions like pneumonia. Okay, pulmonary capillary wedge pressure or the PCWP, it will get increased more than 18 mm of Hg in the cardiogenic pulmonary edema. Why? Because it is happening due to the left side heart failure. So left heart failure means pressure in the left side atrium will be increased, pressure in the pulmonary veins will be increased, and the pressure at the lungs capillary will be increased. Okay, so in the cardiogenic pulmonary edema, the pulmonary capillary wedge pressure will be increased, and in the non-cardiogenic pulmonary edema, it will be normal or the low only. Okay, so then comes to the chest X-ray. Okay, so I told in the ARDS it will see the bilateral infiltration. Okay, and no cardiomegaly. So no cardiomegaly means the cardiophrenic ratio will be normal. Okay, so in the non-cardiogenic pulmonary edema or in case of the ARDS, the cardiophrenic ratio is normal. Okay, so in similar in the cardiogenic pulmonary edema which happening due to the heart failure means cardiomegaly will be there. Okay, so heart will be big, cardiomegaly will be there, the heart will be big means the cardiophrenic ratio will be increased here. Okay, so do remember the cardiophrenic ratio will be increased in the cardiogenic pulmonary edema and cardiophrenic ratio will be normal in the non-cardiogenic pulmonary edema. Okay, so next come to the onset. Okay, so it will be heart failure will not happen in one day, it will be a progressive chronic situation. Okay, so gradual onset will be there in the cardiogenic pulmonary edema. In the non-cardiogenic it will be sudden and acute. So the Berlin's criteria, what it will say, it will happen so sudden. Okay, within 1 week of the insult at the alveolar level. Okay, so then BNP, that is the brain natriuretic peptide, it will be elevated because it is the cardiac failure is there. Okay, the cardiomegaly, cardiac damage is there, so that is the reason the BNP or the brain natriuretic peptide will be increased. Here no cardiogenic failure, so it will be normal in the non-cardiogenic. Okay, so next comes to the echocardiogram or the 2D echo. It will be abnormal because there is in the heart failure or there is in the cardiomegaly, so abnormal echocardiography will be seen in the cardiogenic pulmonary edema. Okay, in the non-cardiogenic pulmonary edema, the 2D echo or the cardiography will be normal. Okay, so then the hypoxia, whatever the thing happening whenever the oxygen will be given, so it will be responsive and it will be easily recovered in the cardiogenic pulmonary edema. But in the non-cardiogenic, due to the alveolar level massive damage, okay, so there will be a refractory hypoxia will happen. Okay, so even if we are giving the oxygen therapy, it will not respond, and the particular what we can say saturation it will not be get increased. Okay, so that is the very important on the ARDS. Okay, so hope it is very much clear to every one of you. Right, the next question is here for your waiting for your best answer in the comment box. So please do read the question carefully, completely, and try to give the best answer in the comment box. Entire ARDS and the difference between the cardiogenic non-cardiogenic pulmonary edema is completely clear. Okay, so if you have any doubt, so please do mention in the comment box. Okay, at the end of the video I will try to respond to your answers. Okay, your questions also. Right, so yes, here's the next question. A patient with acute asthma exacerbation develops a fatigue, drowsiness, and the rising in the PaCO2 is there. What type of the respiratory failure is this? Option A, type 1 respiratory failure. Option B, type 2. Option C, type 3. And option D, type 4 respiratory failure. So what is the correct answer? In an acute exacerbation of the asthma, the patient is having the fatigue, drowsiness, and there is in the PaCO2 is raised here. Okay, so that is the PaCO2 rising means it will be a hypercapnic. Okay, so it will be a situation what you call as in the hyper means increased, capnic means so that is the increased carbon dioxide level. Okay, so this is the hypercapnic respiratory failure. Okay, but a type 1 respiratory failure we call this one as in the hypoxic respiratory failure. Okay, so that is hypoxic means in this situation PaO2 is decreased and PaCO2 is normal, but in the given question the PaCO2 is rising. Okay, increasing. So that is the not our option A goes, it is not correct answer. In the type 2 respiratory failure, okay, this is what you call as in the hypercapnic. Okay, so this is what you call as in the hypercapnic respiratory failure. Okay, in this particular situation what happens, the partial pressure of the oxygen it may decreases or it may be normal, but partial pressure of carbon dioxide is increased. So this is what you call as the hypercapnic respiratory failure. Okay. So this type 3 respiratory failure, which is happening due to the atelectasis, that is due to the post-operative atelectasis. Okay. So due to the general anesthesia effect, the atelectasis is happening. So that is the type 3 respiratory failure. Okay. So type 4 respiratory failure, the respiratory muscles is not getting the sufficient blood due to the hypovolemia or due to the hypovolemic shock. Okay, hypoperfusion of the chest muscles, which leads to the respiratory failure. That is the type 4 respiratory failure. Yes, for correct answer for this question goes to the option B. So that is the hypercapnic respiratory failure, and all of you have given the correct answer. So hope every one of you have seen my ventilator videos. In the ventilator video only, initially I have discussed about the type of the respiratory failure. Okay, so that last your Norcet question also have came directly. Okay, right, here is the quick revision of the all type of the respiratory failure beta. So we have the respiratory failure. The type 1 is the type 1 respiratory failure is the very important one. So this one is the what we call as the hypoxemic respiratory failure. Okay, so here the hypoxemia, hypo means decreased, oxemia means oxygen in the blood. Okay, so hypoxemic respiratory failure means the partial pressure of the our oxygen is decreased here, and PaCO2 is normal, it is not improving. Okay, so the causes of the very important type 1 respiratory failure or the hypoxemic respiratory failure is the PAP. You can remember the PAP. So that is the pulmonary edema, ARDS, acute respiratory distress syndrome, which may land the patient into the hypoxemic respiratory failure or the type 1 respiratory failure, and the pulmonary embolism. Okay, so you can remember pulmonary edema, pulmonary embolism, and the ARDS are the mostly and the leading cause of the type 1 respiratory failures. Okay, so the treatment of the type 1 respiratory failures, I told in the ARDS also, I told we will give the low volume ventilation. Okay, so low volume ventilation will be given in the type 1 respiratory failure. So please do remember the respiratory failure here. Okay, so the next, the type 2 respiratory failure here. So in the type 2 respiratory failure, so we call this one as the hypercapnic respiratory failure. Okay, so hypercapnic means, hyper means increased, capnic means PaCO2. Okay, so that is the hypercapnic means increased carbon dioxide will be there. Okay, so the causes like PaCO2 will be increased and PaO2 decreased, or it may be a normal. Okay, so causes, when it will comes to the causes, so that will be a COPD, a very important. This was your last Norcet question. Okay, so before Norcet also I have discussed this point in the ventilator part. Okay, so this one directly started in our Norcet 8.0. So a cause of the type 2 respiratory failure, that is the COPD, right? In the asthma also type 2 respiratory failure will happens. Okay, so in the diaphragmatic palsy, like in case of the Guillain-Barré syndrome, okay, and in case of the poliomyelitis, okay, these are the conditions where the nerve will get infected and the nerve will get damaged, and the situations where the respiratory muscle paralysis will happen. Okay, so in the diaphragmatic palsy or the respiratory muscle paralysis, so in this particular situation also a hypercapnic respiratory failure will happen. Okay, so please do remember the very important one, and the COPD will be very frequently and the most common cause, so we can say, and it will be a examiner special question. Okay, so in the COPD, okay, in the last class also while discussing the COPD, I told in the COPD which type of the respiratory failure happens. So that is the hypercapnic respiratory failure will happens in the COPD. Okay, so hope it is clear to every one of you. Yes, due to the ascending paralysis in the GBS. Okay, so paralysis will happen from the lower part. Okay, and it will comes up, and the respiratory muscle paralysis will happen, and the patient will die due to the respiratory failure. Okay, in the GBS or in the Guillain-Barré syndrome. Okay, so hope it is clear to every one of you. Yes, so this is what you call the type 2 respiratory failure. So in the type 2 respiratory failure, we will give a treatment. So that is the non-invasive ventilation, tight fitting mask, and we will give the continuous positive pressure ventilation in a patient with a hypercapnic respiratory failure in order to meet the oxygen need of the patient. Okay, so the type 3 respiratory failure is happening due to the post-operative atelectasis. But during the surgery period, okay, we will give the general anesthesia, which will make all the body parts and muscles to get relaxed and paralyzed. Okay, for this short period of the time, it will get relaxed all the body muscles. So after the surgery, patient's body muscles, especially respiratory muscles, will not recover immediately. So it will take some time. So in that particular situation, we will advise the patient for the deep breathing exercises, and along with that, we will advise the patient to use the spirometer. Okay, so for the proper lung expansion in order to avoid the atelectasis. If the patient is not doing the pulmonary exercise or the spirometry, and the physiotherapy is not performing in the post-operative period, means the atelectasis, means the collapse of the alveoli of the lungs will happen. So that is what we call the post-operative atelectasis or the type 3 respiratory failure. Okay, very, very important. Hope it is clear to every one of you. In order to prevent this one, we will give the physiotherapy and oxygen to the patient. Okay, so that is the important thing, right? So next, type 4 respiratory failure, which is happening due to the decreased perfusion to the respiratory muscles. Okay, I told in a hypovolemic shock. Okay, so all the fluid volume is deficit in the body. So there is deficit fluid volume in the body, means yes, all the vital organs will get the less perfusion or the less blood supply. Similarly, respiratory muscles will also get the less blood supply. So due to that one, the respiratory muscles are not functioning properly. So that is what we call as the hypoperfusion respiratory failure or the type 4 respiratory failure. So the treatment here will be the treat the cause, the fluid resuscitation will be done. Okay, so this is the golden point chanting on the all the type of the respiratory failures. Okay, so here is the next question in front of you all. So please do read the question carefully, properly, and try to give the best answer. I'm waiting for your answer in the comment box. Yes. A 35-year-old male presents with a sharp chest pain that worsens with the deep breathing and the coughing. On auscultation, a pleural rub is heard. So what is the most likely diagnosis? Option A, myocardial infarction. Option B, pneumothorax. Option C, pleurisy or the pleuritis. Option D, pericarditis. So what is the correct answer? What is the correct answer? Here we have the 35-year-old male, and he is having the sharp chest pain or the sharp knife-like chest pain also we can say. Okay, so which is worsening during the deep breathing. Okay, so the chest pain is worsening with deep breathing and coughing. Whenever we will auscultate the lung field, so that time the pleural rub is heard. Okay, yes, beta, pleural rub means there is a friction sound which happens due to the inflamed pleural cavity. Okay, so if the pleural cavity is rubbing each together, together, so that will create the pleural friction rub sound. So that one we are hearing in the auscultation. The most likely diagnosis is the, yes, almost all you people give the correct answer. That is the pleurisy goes to the very, very important diagnosis, or we call this one as in the pleuritis also. What is the another name of the pleurisy? We call this one as in the pleuritis also. So what happens, generally consider, okay, this is the lung. Okay, so this one is the lung. Okay, so this lung which is having the two layers of the covering. Okay, so one is the covering which directly covers the lung, so that is what you call the visceral pericardium. Okay, so one more we have here is the, so that is the lung covering. So this one what you call is the parietal, sorry, the visceral pleura and the parietal pleura, not pericardium. Okay, so this is the lung tissue, and the first covering of the lung tissue is the our visceral pleura. Okay, so the pleura which is direct in contact with lung tissue is that is the visceral pleura, and the pleura which is away from the lung tissue is the parietal pleura. Okay, so here in this particular situation, okay, the space between the two pleural cavity we call as the pleural space. Okay, so this is what you call as the pleural space. Okay, so usually this pleural place is having the normal amount of the fluid. Okay, so if in case here the inflammation is happening, so that is what we call the pleuritis. Okay, infection and inflammation of the pleura, we call that one as the pleuritis. Okay, so whenever there is when the patient is having the pleuritis, so whenever the patient will take the deep breath, that time this visceral pleura and parietal pleura will be rubbed together. Okay, so that will form the pleural friction rub. Okay, so this will form the pleural friction rub sound. Okay, so pleural friction rub sound, it will coming due to the friction between the parietal pleura and visceral pleura due to its inflammation. Okay, if there is no any infection, if there is no inflammation means, so pleura, even if it is rubbing together means, it will not comes a sound. Okay, so if it is inflamed and it is rubbing together means, it will forms the pleural friction rub sound. Okay, so that is the very important one, right? So the pleural friction rub sound will be seen in case of the pleuritis. Okay, so whenever the patient will take the deep breath, okay, that time this particular lung will expand more. Okay, so that time again this particular friction is happening. So due to the deep breathing and due to the coughing, okay, so there is due to the coughing in the during cough also lungs will suddenly expand. Okay, so that time this both pleura will rub together. Okay, so during coughing or the deep breathing, sudden sharp knife like pain is happening. Okay, so someone is taking the knife and he is pricking inside the chest, so like this pain will happening to the patient. Okay, sudden, okay, and sharp knife like pain which happening due to the coughing and the deep breathing. So that is what you call as in the patient is suffering with the pleuritis or the pleurisy. Okay, so please do remember the very important clinical scenario, so which will be arised in front of you in the exams. Okay, so the patient is having the sharp chest pain that worsening due to the deep breathing and the coughing, and the pleural friction rub is heard on the auscultation. So the likely diagnosis will be our pleurisy or the pleuritis. Okay, so hope it's clear to everyone of you. So let me quickly revise all the golden points on the pleurisy or the pleuritis. Okay, so pleurisy we also call as in the pleuritis. Okay, that is the inflammation of the pleural cavity. Okay, so here the sign symptoms will be sharp stabbing. Okay, or we can say this is the knife like pain. Okay, someone is taking the sharp knife and he is pricking inside your chest. So whenever in that particular time, how the pain will be felt, so that kind of the pain will be there. Okay, sharp stabbing knife like pain. Okay, which worsens with the deep breathing and coughing. So it is worsening because there is in the lung expand during the deep breathing and coughing. So again the pleural cavity will be rubbed together. Okay, so because of that there will be a pain will be worsens or pain will be increased during the deep breathing and coughing. So please do remember. And pain will be localized to one side. Which side pleurisy is there? That side only the pain will be there. Okay, so not bilateral lung. So not in the both side of the lung. If the right lung is having the pleurisy, so the pain will be happening only in the right lung. If the left lung or the left pleural cavity is having the pleurisy, so pain will only happens in the left side, not in the both sides. So pain will be localized to one side. Okay. So pleural friction rub we will heard during the auscultation. Okay, and the deep and shallow breathing also will happen due to the pain. Okay, so patient is taking the the patient will breathe very shallow. Okay, so why? Because the patient is taking deep breath means the chest pain is happening. So in order to avoid the pain, the patient will take a narrow and shallow breathings. Okay, so that will be happens during the pleurisy case. Okay, the treatment will be main thing will be to reduce the pain. Okay, so in order to reduce the pain, so I will give the NICD. So the best one I am giving here to reduce the pain of the pleura is the ibuprofen. Okay, so the position we will give during the pleurisy is the our very important. Ask the patient to lie on the affected side. Okay, if the the right side of the pleura is affecting, so ask the patient to lie on the right side. Left side is affecting means ask the patient to lie on the left side. Okay, why? Because the pleural friction will not happen if we create pressure on that one. Okay, so it will splint the chest. Okay, so it will splint the chest. So that is the reason ask the patient to lie on the affected side and treat the inflammation. Okay, and we need to treat the inflammation. If it is infection, so you go for the antibiotics. Okay, if it is infection, so we will go for the antibiotics also. Okay, so this is how we will manage the patient with the our very important, what we can say, pleurisy or the pleuritis. Okay, so next we are discussing the concept is, so that is on the very important situation. So that is pleural effusion. So this is the very important situation for your exam. Okay, so we will discuss all the possible questions concept on the pleural effusion. So because this one is the high standard and the gold standard concept for your upcoming exam. Okay, so please do read the question carefully, completely, and try to give the best answer in the comment box. I am waiting for your answer in the comment box. Yes. Which physical finding is most commonly associated with the pleural effusion? So I'm waiting for your answer. Yes. Which physical finding is most commonly associated with the pleural effusion? Option A, resonance on the percussion. Option B, hyperresonance on the percussion. Option C, decreased breath sound and dullness on the percussion. Option D, tympanic sound on the percussion. So what is the correct answer? What is the correct answer? Yes. Fatapat, do mention your answer. Yes, almost all you people given the correct answer. So that is the decreased breath sound and the dullness on the percussions is the classical. So which dullness will happen here? So classical, which dullness will happen here? So that is the stony dullness. We will study. Okay, stony dullness. Stony dullness on the percussion is happening. Okay, which means there is the fluid is accumulated inside the lung. Okay, so whenever you will auscultate, you will get the decreased breath sounds or the absent breath sounds. So we can say, okay, so that one will be seen in case of the pleural effusion. So let me quickly revise all the golden points on the physical findings on the particular pleural effusion. So consider beta. So this is our normal lungs. Okay, so this is our normal lung, and this is the trachea which is there actually in the midline. Okay, so this is the trachea in the midline, and this space we call this one as the mediastinal space. Okay, so this particular space in between the two lungs we call this one as the mediastinal space. Okay, so usually normally trachea will be in the midline. Okay, so this is the normal thing, right? And the each lungs, okay, so that may be a right lung, that may be a left lung, which will be covered with the layers of the lungs. We call that one as the pleural layers. Okay, so the layer which is directly lying on the lungs, so that is what we call as the visceral pleura. Okay, so layer which is lying outside the, okay, so or the away from the lung tissue, so that is what we call as the parietal pleura. In between the visceral pleura and parietal pleura, so there will be accumulation of the fluid. So there will be accumulation of the fluid. So this accumulated fluid, what we call this one is in the effusion. Okay, so pleural effusion. Okay, so this is the normal tissue and lungs. Okay, so here will be below the normal lungs in the pleural space, the fluid is accumulating. Better in the pulmonary edema, what happened? In the pulmonary edema, the fluid is accumulated here inside the lung tissue. Okay, not in the pleural space. In the pulmonary edema, fluid is accumulated inside the lung tissue, and the pleural effusion, in the pleural effusion, the fluid is accumulated outside the lung tissue, okay, in the pleural cavity. Okay, so which creating the pressure on the lung, and consider normally lung should be, okay, till here. Normally lung should be till here, okay, but due to the accumulation of the fluid here, so which created the pressure on the lung and which moved the lungs upward. Okay, so now here we don't have the lung tissue, right? So now here we don't have the lung tissue. So now I will keep the stethoscope here and I will hear for the sound. So there is no lung tissue, means there is absent breath sound will be heard. Okay, absent breath sound will be heard. But in the pulmonary edema, so here the lung tissue is there. Inside the lung tissue, fluid is accumulated. Okay, so in the pulmonary edema, whenever we will auscultate, so that time the crackle sound will be heard. Okay, or we can say the crepitus sound will be heard. In case of the pulmonary edema, we will get the crackle sounds or the crepitus sounds. But in case of the pleural effusion, we will get the absent breath sounds or the decreased breath sounds, because here the fluid is accumulating inside our pleural cavity, not in the lung tissue. This is the very basic concept you have to understand here. Okay, sir, we have understand this one, sir. So then what about the percussion sound, sir? Better normally whenever you will whenever you will tap on the lung tissue, on the normal lung tissue, so that sound it will becomes as the resonance sound. Okay, so normally resonance sounds will be normal in the lung tissue. Okay, So the lung is the air filled cavity. Okay, so normally we will get the normal lung sound. If this lung is hyper air filled, okay, excessive air filled, okay, or the a situation of the air trapping. Okay, so you have already discussed the air trapping which happens in the, okay, so air trapping, where it will happens, air trapping, beta, air trapping, it will happens in the case of the emphysema. Okay, so air trapping means emphysema, or it will also happens in the asthma. The most common complication of the asthma is the emphysema, or it may happen also in the COPD cases. Okay, so the air trapping is happening means in the normally air filled cavity we are getting the resonance sound. Okay, so normally on the chest, so chest is the air filled cavity, we will getting the normal sound, so there is the resonance sound. If in case of the emphysema, asthma and COPD, there is excessive air trapping inside, means this complete lung will be excessively air filled. Okay, so this complete lung will be excessively air filled. So in this particular emphysema, asthma and COPD cases, we will get the lung sound. What you call that one as the hyper resonance. Okay, so which sound we will get? Hyper resonance sound will be getting in case of the air trapping. So that is due to the emphysema, asthma, or COPD, and resonance sound on the lungs is normal. Okay, sir. In the normal lung tissue, we are getting the resonance sound, and in the air trapping, we are getting the hyper resonance sound. Sir, if in case we don't have the lung tissue here, so lung tissue will be like the pleural area will be filled with the fluid. Okay, so on the fluid filled area, if I am tapping means, so it will use the dull sound. Okay, I am percussing on the fluid filled area, it will use the dull sound. Okay, dull sound we will get in the fluid filled area, right? Hope it is clear to every one of you. So very basic thing and very important thing, right? Sir, if in case here the instead of the fluid, so we have the air here, sir, so that is in the pneumothorax. Okay, so accumulation of the air in the pleural space. Okay, if the fluid accumulated, so we are getting the dull sound, sir. If in case the air is accumulated, if in case air accumulated, okay, so air accumulated means, so that is the inside the pleural space air is accumulated means what you call that one as in the, we call that one as in the pneumothorax. Okay, we call that one as in the pneumothorax. But in the pneumothorax, so this particular area is not filled with the fluid, and this particular area is not filled with the tissue also. So only it is empty and only air is there inside. Okay, so that is the empty area we can say. Okay, or only air accumulated area or the empty area. So we will get the tympanic sound. Okay, on the percussion we are getting the tympanic sound means that is the case of the pneumothorax. On the percussion we are getting the dull sound means that is the case of the pleural effusion. On the percussion we are getting the hyper resonance sound means, so that is the case of the emphysema, asthma, or the COPD. Okay, so very important, you please do keep in your mind. Okay, so hope it is clear to every one of you. Yes, I will give the situation now. Try to give the best answer in the comment box. Okay, beta, on the auscultation, please make this particular chart here. So this will be very much easy you people to understand the scenario in the exam and to choose the correct answer. Okay, so on the percussion, right, so the condition, just these two things are very importantly, it will give the clue, and other clue will be there in your exam, but so this is very important and basic, you have to understand. Okay, on the auscultation, there is absent breath sound. Absent breath sound is there. Okay, on the percussion we are getting the tympanic sound. We are getting the tympanic sound. So what is the case? What is the condition? The condition is pneumothorax, because if we are getting the absent breath sound and tympanic sound on the percussion, so condition is pneumothorax. Along with the absent breath sound, if we are getting the a sound what we call as in the dull sound, so that is the case of the pleural effusion. So please do understand the concept here. Okay, so in the pneumothorax there is on the accumulation of the air is there, so we are getting the very important tympanic sound. Okay, so on the auscultation we are getting the Again absent breath sound. Okay, on the auscultation we are getting the absent breath sound, and on the percussion we are getting the dull sound. So what is the situation? This situation we call this one as in the a case of the pleural effusion. Okay, in the pleural effusion also absent breath sound will be there, and in the pneumothorax also absent breath sound will be there. But on the percussion, tympanic sound is coming means there is the pneumothorax. On the percussion, dull sound is coming means there is the pleural effusion. This is how we have to differentiate between the these two very important situation. Okay, because it is important for your exam. Okay, so the differentiation point is here on the percussion. Okay, so the percussion sound is here to differentiate the things, right? So comes to the question now. So in the question, what happened? Which physical finding is most commonly associated with the pleural effusion? Better. So decreased breath sound and the dull sound. Okay, so that is what we call it in the pleural effusion. Okay, if the resonance on the percussion is coming means on the normal lungs. Okay, resonance will comes on the normal lungs. Hyperresonance will comes in the air trapping situations called as the emphysema or the COPD, or we can say asthma. There will be a hyperresonance sound on the percussion. Okay, so tympanic sound on the percussion, yes, this will be seen in case of the normally it will be seen on the stomach. If you are doing the percussion on the empty stomach, so the normal tympanic will be seen, but the tympanic on the chest, tympanic sound on the chest, if we are getting this, so that is indicating the pneumothorax. So hope it is clear to every one of you. Okay, so this is the very basic thing you have to understand here, right? Sir, let me discuss all the golden point chanting on the pleural effusion. So this will be a very basic thing and very important thing. Okay, so normal pleural fluid, how much we have? The normal pleural fluid we have is the 5 to 15 ml. Okay, so that is normally very much less in the protein. Okay, that is the less than 1.5 mg per deciliter, and the LDH is nothing will be there. Okay, no any lactose dehydrogenase, or the LDH will also be not there. Okay, in the normal pleural fluid. Okay, so normally we have the fluid inside the pleura, so that is the 5 to 15 ml. Up to 20 ml also it will be normal. Okay, but the content of the pleural fluid we are having is the which is less in the protein, that is the less than 1.5 gram. Okay, so that is less than 1.5 gram, 5 milligram per deciliter. Okay, so very important, right? So in the pleural effusion, what happens is the accumulation of the excessive fluid in the pleural cavity will happen. Okay, so that is the situation which we have discussed already in this particular image. Okay, so in this pleural cavity, so there will be accumulation of the excessive fluid which creates the pressure on the lungs. Okay, which moves the lungs upward. Okay, so this will be seen in case of the pleural effusion. Okay, so we have the two types of the pleural effusion. One is the transudate, another one is the exudate. Okay, one is the transudate, means a fluid without any pus, or the fluid which is very much clear. Okay, that is the transudate. Another one is the exudate type of the pleural effusion, where the fluid is containing the pus. Okay, so in simple we can say the composition of the transudate and exudate. Okay, so usually transudate which happens due to systemic failure. Okay, pleural effusion is happening due to the cardiac failure, or the pleural effusion is happening due to the fluid overload. Okay, so that is the transudate which will happen. So okay, in case of the congestive heart failure, okay, the fluid is congested, okay, which is leaking inside the pleural cavity, the congestive heart failure induced pleural effusion, so which will be having the less protein, because there is no infection, there is no any inflammation. Okay, so there is no any pus cells. Okay, there is no any what we can say LDH will be there. Okay, but in case of the exudate, which may happens due to the infection, inflammation, that is TB, pneumonia, and the malignant condition, so it is having the high protein, high pus, and the high LDH. Okay, so but in the transudate, which will be having the less protein, less pus, and the less LDH. Okay, so the transudate is the having the composition of the less protein, less pus, and the less LDH, and the exudate is the which is including the pus cells. Okay, so high pus, high protein, and the high LDH will be there in the exudate. Okay, so transudate which happens due to the deficiency of the albumin. Okay, so the albumin is responsible for the maintaining the oncotic pressure. Okay, so albumin is deficient means there is no any plasma oncotic pressure, the fluid will leak into the pleural cavity. Okay, so that is in the cirrhosis. Okay, you know, from here the albumin will be produced, or from here the plasma protein will be produced? Yes, from the liver. From the liver only all the plasma proteins will be get produced. Okay, so in the liver cirrhosis happening, there is no any production of the albumin. No production of the albumin means, yes, there is no any oncotic pressure, so fluid will leak into the pleural cavity. Okay, in the cirrhosis, okay, this particular transudative type of the pleural effusion will happen. So, okay, the nephrotic syndrome, okay, comes to the nephrotic syndrome. Here, excessive loss of the protein will be there through the urine. Okay, the excessive protein urea will be there in the nephrotic syndrome. So, albumin is getting lost through the urine. So, no albumin, no oncotic pressure. No oncotic pressure means fluid will get leak into the like pleural cavity. So, again, the pleural effusion will happen. Okay, so these are the pleural fluid is getting leak inside the okay, so excessive fluid is accumulating inside the pleural cavity, okay, without any infection inflammation. So there is in the less protein, okay, so less pus and the less LDH will be there. So that will be what we call the transudative type of the pleural effusion. Okay, in case of the exudative, we will discuss it already, which happening due to the TB, which happening due to the pneumonia, which happening due to the inflammation, malignancy. So the infection inflammation will be there. Okay, so infection inflammation will be there means high pus, high protein, and the high LDH will be there. Okay, so we have one criteria. So that is what we call the Light's criteria. Okay, so Light criteria. This criteria is useful for the differentiating between the transudative fluid and the exudative fluid. Okay, so I told in the transudative fluid, yes, the less protein, less LDH, less pus cell. Okay, so whenever we will do the in the Light's criteria, okay, so fluid protein means the pleural fluid protein and the serum protein, the ratio whenever we will do, so that time I told in the transudate everything will be less, so it will be less than or equal to 0.5. Okay, so the ratio between the fluid LDH means the of pleural fluid LDH and the serum LDH, again it is less than 0.6. Okay, then the LDH level in the pleural fluid is less than or equal to 2/3 of the upper limit of the normal LDH in the serum. Okay, so always less is the transudative. Okay, in the exudative, whenever we will see the pleural fluid is to this pleural fluid and the serum fluid protein ratio, so there it will be more than 0.5 is the exudative. Okay, the more protein, more LDH, and the more pus cells is the exudative, I told. Okay, so that is if the fluid LDH means the pleural fluid LDH and the serum LDH ratio is more than 0.6, so that is what we call as the exudative, right? Or it is more than 2, like the LDH level in the pleural fluid is more than 2/3 of the upper limit of the serum LDH. So this is also what we call as the exudative. So do remember, in the exudative everything will increase, in the transudative everything will decreases. Okay, so hope you have clarity about this particular, what we can say, transudative and exudative type of the pleural effusion. Okay, so here we have the next very important clinical manifestation of the pleural effusion. Yes, in the clinical manifestation of the pleural effusion, what we are getting here, so patient is experiencing the dyspnea. So that is the difficulty in the breathing will be there. Why? Because the lung is compromised, the lung is compressed by the pressure. Okay, so now here the fluid is filled and lung is not properly expanding. So lung is not properly expanding means not proper oxygenation is happening. So patient will require the more oxygen and it is unable to get the more oxygen because the lung size is compromised, because the accumulated fluid inside the pleura which created the pressure on the lungs. Okay, so the clinical manifestation, the patient will experience the difficulty in the breathing, so that will be progressive. Okay, so how the clinical manifestation of the pleural effusion will be there? Progressive. Okay, that will be a progressive dyspnea. Okay, dyspnea will not happen suddenly, but in case of the pneumothorax there will be a sudden dyspnea will be there. Okay, in the pleural effusion, like little amount of the fluid will get collect, so little dyspnea means difficulty in the breathing will get increases. Okay, so most common symptom of the pleural effusion is the difficulty in the breathing, especially in the large volume of the effusion. Okay, so there is one more word we can remember, that is the massive pleural effusion. In the massive pleural effusion, so there is sudden accumulation of the more than 250 ml of the fluid suddenly if it is accumulating, so that is what we call the massive pleural effusion. Okay, so do remember the chest pain here, it is the pleuritic chest pain. So that is already we have discussed. The chest pain will worsens with inspiration, and during the inspiration, the deep inspiration we are taking means the the pleura will get irritated. That time the during the inspiration, the worsening of the pleuritic pain will be there. Okay, so next, beta, if fluid is accumulating inside the lung tissue, consider this is the lung tissue. Okay, so this is the pleura. Okay, this is the bronchi, right? If the fluid is accumulating here or the sputum is accumulating here, whenever the patient will cough, so it will, the accumulated sputum, it will comes out. Okay, that is what we call the productive cough. But fluid is not accumulating inside the lung tissue. Fluid is accumulating here inside the pleural space. How much the patient will cough? From here it can't comes the from here the fluid will not enter into the lung tissue. Okay, so there is no any expectorant, there is no any sputum will come. Okay, so the sputum will be dry sputum, or the cough which is patient is having is the non-productive cough, means cough without any sputum. Okay, so dry or the non-productive cough. So that is the what we can understand here. So cough is happening without sputum. So that is what you call as the non-productive cough. Okay, or the dry cough. Right. The next, orthopnea. Orthopnea means whenever the patient will sleep, so that time he will feel the difficulty in the breathing because of the patient lungs will be compromised due to the fluid pressure on the lungs. Okay, so especially which happens due to heart failure related effusion. So the nocturnal orthopnea will happen, means the night time whenever the patient will sleep, so that time the difficulty in breathing will arise. Okay, so very very important. Already we have discussed points, we will discuss again here. Okay, in the pleural effusion, what happens? The lung which is compromised here. Okay, so whenever we will see externally, whenever we will see the patient lungs, okay, so that time this particular lung which is there here, it will not fully expand. Why? Because there is a pressure is there by the fluid. Okay, but the normal side lung, so this side lung, it will completely expand, but this lung will not completely expand. Okay, if both are expanding equally, we call it the symmetric lung expansion. So due to the pleural effusion or due to the pressure by the fluid on the chest wall, okay, so one side lung will expand completely and another side lung will not expand completely. Okay, so we can say this is the asymmetrical lung expansion. Okay, so we can call this one as the asymmetrical lung expansion. Okay, so one point is clear. On the inspection, whenever we will see the patient with the what we can say, pleural effusion. Okay, whenever we will inspect the patient with the pleural effusion, so asymmetrical lung or the asymmetrical chest expansion will be there. So because of the affected side lung will not expand completely. Okay, so affected side may move less during the respiration. Okay, so that is due to the accumulation of the fluid. One side of the lung will expand, normal side one will expand. So wherever the fluid accumulated, that side it will not expand. Okay, so it will be called this one as the asymmetrical chest expansion. We will see on the inspection of the patient. Okay, so in the X-ray of the patient with the pleural effusion, so whatever the thing we will see here is the, so look at this particular X-ray. Okay, so I told in the initial period, so trachea should be normally like this in the midline. Okay, so trachea or the windpipe normally should be like this in the midline, but this side the fluid is accumulated. Okay, so which created the pressure and which move the trachea to deviate opposite side. So now trachea is like this. Okay, so trachea deviation is happening towards the opposite side. Okay, so towards the opposite side, and so this is the space, what we call this one is the mediastinal space. Okay, the space between the two lungs. Okay, so due to the pressure here, this mediastinum also shifted opposite side. So mediastinum shift will be their opposite side and the tracheal deviation will be their opposite side. Okay, or we can say unaffected side shifting. Okay, so this is the affected side. Wherever the pleural effusion is happening, so that one is the affected side. Okay, so this one is the unaffected lung. The trachea deviation will happens towards the unaffected side, or the mediastinal deviation will happens towards the unaffected side. Okay, so very very important. Please do keep in your mind. Right. So here here are you able to see this particular, actually the lungs should be still here. Okay, due to the accumulation of the fluid, the lungs have been pushed up. Okay, so now the lungs still here only, right? So here it makes the semi-lunar or the crescent shape or the half moon shaped line. So this is what we call as in the a semi-lunar or the crescent shaped line. So this line we will call this one as in the meniscus sign. Okay, so what we can call this one as in the, yes, we call this one as in the meniscus sign, which is positive here. Okay, so then mediastinum will be shifting opposite side and the trachea will be deviated. Okay, trachea will be deviated opposite side, trachea will be deviated on the unaffected side. Okay, mediastinal shift will be there in the unaffected side and meniscus sign will be there in the x-ray, and the blunt costophrenic angle will be there in the x-ray. Okay, sir, how to identify blunt costophrenic angle, sir? Sir, this side lung is normal, so this particular angle, this is the diaphragm. Okay, and this is what we call the phrenic also, and this is the costal margin. So this costal margin is very sharp here. Are you able to see? This costal margin is very sharp here in the normal lung. Okay, so are you able to see the costal margin in the pleural effusion side? No. So this one will be blunted costophrenic angle will be there. Okay, sir, in the pleural effusion we will get the blunt costophrenic angle, meniscus sign positive, mediastinal shift to the opposite side or the unaffected side, and the trachea deviation to the opposite side or the unaffected side. So these are the very, very important point. Okay, so are you able to see the difference between the normal chest x-ray and the what we can say pleural effusion chest x-ray? Yes. So look at this particular image. Here we have the a sharp costophrenic angle. Okay, here also we have the sharp costophrenic angle because this is the normal lung. Okay, so here you are able to see till this lung should be there, but here the fluid have been accumulated and the costophrenic angle. So the angle here is the very much blunt here. Okay, so this is the blunt costophrenic angle we can say. Okay, blunt costophrenic angle will be seen in case of the pleural effusion. Okay, so wherever the part which is looking white, which is the indicating the fluid, wherever the air is there, so that is the black. Okay, so air filled area will be black normally. Okay, so this is the air filled area, so which is the black, and this white portion is the fluid filled area. Okay, so that is the very, very important. So as a basic thing you have to understand here, right? So hope it is clear to every one of you. The X-ray of the pleural effusion. Okay, so next, whenever we will do the percussion, okay, so already we have discussed on the fluid filled area. I am doing the percussion, so there is in the stony dull percussion will be there, the classical sign of the fluid filled area. Okay, so on the percussion I am getting the tympanic, means the air filled one. Okay, so tympanic means I will get in the case of the pneumothorax. Okay, not in the pleural effusion, right? So on the normal lung, normally resonance. On the air trapped lung, hyperresonance. On the air filled pleural space. Okay, so that is in the pneumothorax, so there will be a tympanic sound. Okay, on the auscultation we have already discussed absent breath sound or the reduced breath sound will be there. Okay, so we have discussed this one already. Okay, so on the tactile parameters, whenever we will do the tactile parameters, so that will be a decreased tactile parameters will be there. Okay, so what is the tactile parameters? Better. So we will keep the both the hand on the chest of the patient, and we will ask the patient to say the 99, 99, 99 like this. Okay, sir, whenever I am saying the 99, 99, the vibration will create here. Okay, so normally if the lung is consolidated with the pus and fluid, that time the vibration will be more. Okay, so whenever the lung tissue, okay, this is the lung tissue. Okay, inside the lung tissue there is accumulation of the pus fluid will be there. Consider it is the case of the pneumonia, consolidated lung. So at that particular time, whenever the patient will say the 99, 99, there will be a more vibration. There will be a more vibration. So in the pneumonia, tactile parameters will increases. But in the pleural effusion, what happens? In the pleural effusion, what happens? this is the pleural cavity and the fluid is accumulated here. Okay, so the fluid is accumulated here, right? So now the fluid is accumulated here means the lungs will be pushed off. Okay, so the lungs will be this particular lung which is there inside, it will be pushed off. Okay, like this much only will be the lungs. Okay, so remaining area will be accumulation of the fluid will be there. Okay, so whenever I will keep the hand here, okay, whenever I will keep my hand here on the fluid filled cavity, okay, the patient is saying 99, but the vibration is not coming till here. Okay, so in the pleural effusion the tactile parameters will be decreased. Okay, so in a case of the pneumonia or in the consolidated lung, okay, so the tactile parameters will be increased. Very basic thing, please consider the special point and the special information for you all. Okay, so hope today's session you people have enjoyed a lot. Okay, so in the tomorrow session again I will come with the lots of the golden point chanting and the revision. Okay, so this pleural effusion is still not over, so we need to discuss the question on the concept on the pleural effusion more. Okay, so still we have the like discussion on the pleural effusion. Okay, I will discuss in the next part, so please be stay connected and keep preparing, so it will be very much helpful for you all. Okay, so hope you have enjoyed the session and we will meet again in the tomorrow session with lots of the information and the lots of the question discussion and concept discussion. Okay, so thank you so much for watching the video till the end. Okay, so we will meet again in the tomorrow session. Tab tak ke liye jai hind, jai bharat, love you all, take care, bye bye.